All right, let's go ahead and start the grand rounds. Rashmi D'Mello, who is an Allergy Immunology Fellow in our program, is going to present grand rounds today. She's going to talk about allergic bronchopulmonary Aspergillosis. So, turn it over to you.
Thank you, Dr. Bocchini. So good morning, everyone. My name is Rashmi D'Mello. Like Dr. Bocchini said, I'm an Allergy Immunology Fellow here at LSU Shreveport. And I'll be talking about allergic bronchopulmonary aspergillosis today. So I have no disclosures for this talk. Just some objectives for today's grand rounds is to define allergic bronchopulmonary aspergillosis, abbreviated as ABPA, and identify high-risk patients, the evaluation of patients with suspected ABPA, and then lastly, the management of ABPA. So some history about Aspergillus. The mold Aspergillus was first described in 1729 as it looks like aspergillum, which is the Latin term for a device used to sprinkle holy water. An association with human disease was first described in 1847 of a woman dying with an unspecified lung infection. In 1856, there were 4 cases of pulmonary aspergillosis in patients dying of other conditions. In 1887, there was a case report of a young woman who coughed up sputum and mycelia along with spores of Aspergillus. And then nearly a decade later, Aspergillus was finally associated with asthma. That same year, between 1 and 20% of patients with asthma had positive skin tests to Aspergillus extracts. So the first report of ABPA was reported in 3 patients in 1952, all of whom were asthmatics, and they presented with a persistent wheeze, sputum production, fever, eosinophilia, and pulmonary infiltrates. So ABPA can be caused by a variety of Aspergillus species, most commonly Aspergillus fumigatus, but there are other species that have been implicated, such as A. niger, A. flavus, Aspergillus nigellans, Aspergillus oryzae, and Aspergillus terreus. There's a few more that I haven't listed as well. There's other fungi other than Aspergillus that have known to be implicated, and this gives rise to the term allergic bronchopulmonary mycosis, abbreviated as ABPM. So these can include Candida, Helminthosporium, Curvularia, Bipolaris, and Cladosporium. Aspergillus is a saprophytic mold, and its natural habitat is in the soil. So it's found worldwide, indoors and outdoors, in potted soil, compost, freshly cut grasses, decaying vegetation, and also in sewers. Aspergillus produces a bountiful number of spores and releases about 2 to 3 micron-sized spores into the air daily. It grows best at 37 to 40 degrees Celsius, which is also the temperature or a similar temperature in our lungs. These spores will remain airborne for a long period of time. It is estimated that humans inhale hundreds of spores daily. So in general, just conidia are usually eliminated in an immunocompetent host by neutrophils. So these are 2 images. The image on the left is Aspergillus fumigatus with light microscopy, and on the right it's electron microscopy. And you can see they look like stalks with almost, like a fuzzy kind of top on top. And then those are the conidia that you see right here, all around it, and even these on the electron microscopy. So what is ABPA? Allergic bronchopulmonary aspergillosis is a slowly progressive disease resulting from a hypersensitivity response to the presence of the fungus Aspergillus, most commonly Aspergillus fumigatus, in the airways, and usually affecting subjects with asthma and cystic fibrosis. So in this lecture particularly, we'll be talking about Aspergillus fumigatus. The precise prevalence of ABPA in asthmatic patients varies widely and is based on the severity of asthma, presence of immediate hypersensitivity to Aspergillus, and method of detection, as well as diagnostic criteria. Therefore, the precise prevalence of ABPA in patients with asthma and in cystic fibrosis is unknown. It is estimated that about 2% of asthmatic patients and 1 to 15% of cystic fibrosis patients have ABPA. It usually occurs in the 3rd and 4th decades of life with no gender predilection. There are high levels of outdoor spores, which may be associated with ABPA exacerbations, but a clear relationship between the level of exposure to Aspergillus and the occurrence of ABPA has not been established. So this is a diagram of the spectrum of Aspergillus diseases. In a normal host who inhales Aspergillus spores, there's no sequelae to be found. Like we talked about, it usually gets eliminated by neutrophils. And the most common organ affected by aspergilloma is the lung. So aspergilloma mainly affects individuals with underlying lung diseases such as TB, sarcoidosis, bronchiectasis, cystic fibrosis, and then sometimes immunodeficiency as well. In patients with some degree of immunocompromise who present with progressive features over 1 to 3 months, they usually are found to have subacute invasive pulmonary aspergillosis, or it's also known as chronic necrotizing aspergillosis. And then invasive pulmonary aspergillosis is usually seen in an immunocompromised host. And then in our topic, we'll be talking about asthma and cystic fibrosis patients that will typically develop ABPA. So the pathogenesis of ABPA remains incompletely understood. It's based mainly on in vitro studies, but there are multiple theories that have been proposed regarding the pathogenesis of ABPA. The most common theories suggest that in patients with a genetic predisposition and increased pulmonary viscosity, for example, in patients with asthma and cystic fibrosis, inhalation of spores from Aspergillus fumigatus may result in persistent colonization and deposition of hyphae, releasing antigens. So on this slide, you can see that the antigens disrupt the epithelial barrier, they damage mucociliary clearance, and then they activate the innate immune response, ultimately resulting in an influx of inflammatory cells and the release of cytokines. And then this propagates neutrophilic inflammation and early and late phase inflammatory reactions. And then on this slide, you see that the fungus also has proteolytic enzymes, which release antigens that cause skewing of Th2 over Th1 cell response after processing of the antigens by dendritic cells. So these release Th2 cytokines, IL-4, IL-5, IL-13, resulting in the propagation of inflammation as well as significant eosinophilic inflammation, causing tissue damage and production of IgE. Tissue damage and bronchiectasis result from the pulmonary influx of eosinophils and neutrophils. In the lungs, this can also cause central bronchiectasis. So pathology is not necessary for diagnosis. This is characterized pathologically by mucoid impaction of the bronchi, eosinophilic pneumonia, and bronchocentric granulomatosis, in addition to histologic features of asthma. So areas of eosinophilic pneumonia are occasionally found, but they're not a major feature of the disease. Septated hyphae with acute dichotomous branching may be seen in the mucus-filled bronchial lumen, but fungi do not invade the mucosa. Aspergillus is also cultured from the sputum in up to two-thirds of patients with ABPA, but the hyphae may not be seen by direct microscopy. Some of the key findings that you can find in sputum are Kirschmann spirals, which are essentially mucus plugs, and eosinophilic debris, also known as Charcot-Leyden crystals. So the image on the left is a bronchial lumen that is filled with numerous inflammatory cells, cellular debris, mucus, and fibrinous material. Both images are H&E staining, and the image on the right is actually layered mucus and inflammatory cells and debris that occupy the lumen of a bronchus. In this image on the left, you'll see multiple aggregates of eosinophils and Charcot-Leyden crystals. So the Charcot-Leyden crystals are actually these pink crystals that you see. And they're present in a background of mucus, so that's all the white that you're seeing. There's also several fungal hyphae with features of Aspergillus, which are seen, and these are the fungal hyphae. There's a few that are pointed with the arrow. And then the image on the right is actually methylamine silver staining, and it's small numbers of fragmented hyphae that lie in an inflammatory exudate, and the culture showed Aspergillus once again. And these are the hyphae that you're seeing. So this is just an image of bronchocentric granulomatosis. So the diagnosis of ABPA should be based on clinical suspicion and supported by radiologic and laboratory findings as well. An important clinical feature of the presentation of ABPA is deterioration of pulmonary symptoms with increased wheezing and shortness of breath. The patients typically will present with fever, malaise, a productive cough with brownish mucus plugs, and occasionally hemoptysis. Diagnosis is typically suspected in patients with recurrent asthma or cystic fibrosis exacerbations. So it is important to rule out other causes before committing to the diagnosis of ABPA. Could this simply be an asthma or cystic fibrosis exacerbation and they improve with treatment? Or are there other causes? So other causes of bronchiectasis include post-infectious causes, immunodeficiency, or ciliary dysfunction. There are also other causes of eosinophilia, eosinophilic pneumonia, eosinophilic granulomatosis with polyangiitis, formerly known as Church-Strauss, hypereosinophilic syndrome, hypersensitivity reactions, and parasitic infections. In general, the evaluations should consist of obtaining a complete blood count with differential to evaluate for eosinophilia, skin prick test to Aspergillus, a specific IgE to Aspergillus, serum precipitins or IgG antibody to Aspergillus, a chest x-ray, and a high-resolution CT of the lungs. If the skin prick test is negative, intradermal testing can be considered. In general, specific IgE to Aspergillus alone suggests sensitization only, and this is not diagnostic of ABPA. This is frequently present in patients with severe eosinophilic asthma, so it's important to keep that in mind. Total serum IgE should also be obtained because this is very useful when it comes to monitoring.
Is the skin prick test a delayed type hypersensitivity reaction or an acute reaction?
Immediate. Yeah.
Both actually.
Can be both. Yeah.
Yeah.
So
It must be both. That immediate will be ready in 20 minutes, and after 4 to 6 hours, ready again.
So a case presentation. This is a 12-year-old female that presented to LSU and was evaluated by our department, Allergy and Immunology, along with Dr. Killakoide from Pediatric Pulmonary. The patient has a history of eczema and persistent asthma since childhood. She actually follows as an outpatient with Pediatric Pulmonary. So the patient presented with worsening of her asthma and a decline of her flow function on spirometry despite strict adherence to medications. She had persistent wheezing that required the intake of her albuterol inhaler at least 3 to 4 times a day. She had over 10 courses of prednisone during the past year with improvements for only short periods of time. There were no apparent triggers. Her prior history consisted of a severe asthma exacerbation at the age of 8, where she required admission to the intensive care unit. Since 10 years of age, in spite of adequate routine asthma therapy, she had many exacerbations requiring frequent emergency treatment and 5 hospitalizations. In terms of medications, she was on an inhaler, which is a combination of fluticasone and salmeterol. She took 2 puffs twice daily, loratadine that she took in the morning, and montelukast that she took at night. So some laboratory findings when she was admitted. Her CBC was within normal limits, and she did not, her absolute eosinophil count was 100 microliters, but this was taken after corticosteroids were given. Her serum total IgE level was 2,040 international units per milliliter. So this raised the suspicion of ABPA, and actually she had this level drawn as an outpatient where ABPA panels were drawn, but she presented to the hospital before follow-up. Serum-specific antibodies to Aspergillus were also elevated for IgE at 28.5 international units per ml. This is her chest x-ray on admission. She had some hyperinflation bilaterally. She also had streaky atelectasis that you can see in the right middle lobe, and peribronchial cuffing. And then she also had a high-resolution CT of her lungs, but really didn't show any infiltrates or bronchiectasis. So in terms of diagnostic criteria for asthma, we're just going to flip back to the diagnostic criteria for asthma and ABPA. So currently, the most widely accepted criteria are those proposed by Rosenberg and Patterson. In patients with asthma, the severity of their condition does not determine their diagnosis. So the major criteria is presented in red, and it's if they have asthma, not dependent on asthma severity, immediate Aspergillus skin test reaction, precipitating IgG antibodies to Aspergillus fumigatus, a total serum IgE of greater than 1,000 nanograms per milliliter or 417 international units per milliliter, elevated Aspergillus serum-specific IgE and IgG antibodies. And some minor criteria are blood eosinophilia, so greater than 500 per millimeter, chest x-ray or chest CT infiltrates, and central bronchiectasis on CT. And so central bronchiectasis on CT, what we know, or many authors kind of suggest, is that it's not necessarily needed, and that's why there's a star beside it. So many patients do have very high levels of total IgE, often exceeding 10,000 international units per milliliter. And the most sensitive indicator of disease progression, like we said, is measuring and following the total IgE. So another popular group of physicians that came up with slightly different classification is Agarwal, and it's called the Agarwal classification. They propose that all patients diagnosed with asthma must be screened for specific IgE levels to Aspergillus. If negative, total IgE levels and sensitization to other fungi should be obtained to rule out ABPM. In patients sensitized to Aspergillus, total IgE levels below 1,000 international units per milliliter and uncontrolled asthma suggest severe asthma with fungal sensitization as an alternative to ABPA. So this subset of patients, so it's important because this subset of patients can benefit from antifungal therapy. In patients with fungal sensitization to Aspergillus and a total IgE level greater than 1,000 international units per milliliter, clinicians should obtain eosinophil levels, immediate skin hypersensitivity, and specific IgG to the Aspergillus. If any two of the criteria are positive, ABPA is confirmed, and high-resolution CT of the lungs should be performed for staging of the disease. So although there is a little bit of controversy, some authors will suggest a significantly higher total serum IgE level of 1,000 international units per milliliter, which is 2,400 nanograms per milliliter for diagnosis. Most authors currently follow the 1,000 nanograms per milliliter, or 417 international units per milliliter. And also, since central bronchiectasis is not required for the diagnosis, Patients with ABPA can be subdivided into two groups, so ones that present with and ones that present without central bronchiectasis. So diagnostic criteria for cystic fibrosis is a little different, and it includes acute or subacute deterioration, immediate skin test reactivity to Aspergillus antigens or IgE antibodies to Aspergillus, a total serum IgE of greater than 2,400 nanograms per milliliter or 1,000 international units per milliliter, so higher than the asthmatic criteria, IgE antibodies to Aspergillus or immediate cutaneous reactivity, recent chest x-ray abnormalities, so infiltrates or bronchiectasis not improving after antibiotics, and precipitating antibodies to Aspergillus fumigatus or serum IgG antibodies to Aspergillus fumigatus by blood test. So other diagnostic measures, like we said, Aspergillus culture can be obtained from sputum, and this is positive in up to 2/3 of patients. As I mentioned earlier, Kirschmann spirals and eosinophilic debris can also be found. However, these can be found in just asthmatic patients in general without ABPA, so keep that in mind. Precipitants are an initial quantitative measure of antibodies by using multiple Aspergillus antigens that react with antibodies and form complexes demonstrated by precipitin lines. So precipitating antibodies to Aspergillus is by gel diffusion, predominantly of the IgG class, but occasionally IgE and IgA. Precipitating antibodies may also be detectable in several fungal pulmonary diseases, such as aspergilloma. So their detection really doesn't indicate a diagnosis of ABPA. The serum may need to be concentrated 5-fold to even reveal positivity. And patients who have treated ABPA normally do not normally have positive precipitating antibodies. It's not really performed much anymore either.
What do you do then instead?
So we do the serum IgE and IgG in the blood.
IgG antibodies instead.
In the blood. So in terms of pulmonary function testing, this can be valuable in monitoring the disease severity, but not the diagnosis of ABPA. So spirometry typically shows an obstructive pattern, but can also develop restriction in late stages of the disease. After treatment with corticosteroids or during remission, a normalization of these parameters can occur, and that really is the goal of treatment. So in terms of our case presentation, just going back to that, our patient met majority of the criteria. She did have uncontrolled asthma. Her total IgE level was very high. It was 2,040 international units per milliliter. And she had an elevated serum IgE of 28.5 international units per milliliter. And her IgG was 23.7 international units per milliliter to Aspergillus. She did not have any eosinophils, and it's because she was given steroids prior to getting her blood work. And there were also no infiltrates seen really on chest x-ray or high-resolution CT. So in terms of what you would see on a chest x-ray, there can be transient changes, so patchy areas of consolidation, sometimes known as fleeting infiltrates. Also, radiologic infiltrates can be seen as gloved finger shadows due to mucoid impaction in dilated bronchi. And then there can also be a lobar or segmental collapse. Some permanent changes that you'll see are parallel line shadows representing bronchial widening, ring shadows that are 1 to 2 centimeters in diameter, and pulmonary fibrosis, so fibrotic scarred upper lobe with cavitation. In terms of the CT, you can see central bronchiectasis, but this is not necessary. You may also see some mucus plugging with bronchoceles. You can see consolidation, centrilobular nodules with tree and bud opacities, bronchial wall thickening, and some areas of atelectasis. So this is a picture of an X-ray with a patient who had ABPA, and this patient had recurrent pneumonia with fleeting pulmonary opacities on the chest X-ray, and here in black you'll also see the lobar collapse. This is another X-ray. So in the image on the left, you'll see the finger in glove sign. There are other names for it. It does. I feel like this one doesn't look very typical of it, but it can also be called rabbit ear appearance. Can be called Mickey Mouse appearance, Y-shaped opacities, or V-shaped opacities. This refers to a characteristic sign of a bronchoceal. So a bronchoceal is a segment that is filled with mucus and completely enclosed. The mucus can't really drain out. This segment is usually dilated. In the second image, what we'll see with the long arrows is, so you'll see ring shadows, and I don't know if you guys can see it too well, but they're basically just very little ring shadows seen, and then with the smaller arrow, you'll see tram track findings that are seen in bronchiectasis. So this is high-resolution CT. The first patient is a patient with ABPA that you can see lots of bronchiectasis, and then the image on the right is just the upper lobes that you also see bronchiectasis. And tree and bud appearances are present as well. So complications of ABPA include severe bronchiectasis, pulmonary fibrosis, respiratory compromise, and end-stage lung disease. Cystic fibrosis patients tend to decline more rapidly than those with asthma. So like we said, in terms of staging, it is not necessarily progressive. You don't have to go through the stages. A patient can present all of a sudden in stage 4 or stage 5 without any preceding symptoms. So in stage 1, this is the acute phase. It's usually after usually after prednisone, the radiologic infiltrate will clear unless there's fibrosis present. There should be a 35% decline in total serum IgE by 6 weeks of treatment, with usually stabilization of symptoms and a decline in the peripheral blood eosinophilia. In stage 2, that's the remission stage. So this is present when a chest X-ray film will show that the infiltrate has resolved, with decline and stabilization of total serum IgE. Prednisone is tapered and then discontinued, if possible, at this point. In stage 3, that's your exacerbation stage. So there can be reappearance of infiltrates and or mucoid impaction in previously involved or new areas of the lungs. Remission after exacerbation usually follows once treated, so going back to stage 2. In stage 4, this is your glucocorticoid-dependent ABPA. So this becomes apparent when prednisone for ABPA is discontinued with development of severe asthma symptoms. So you're just unable to get the patient off of oral corticosteroids. And in stage 5, that's the end-stage fibrotic ABPA. So at this point, you'll see bronchiectasis, pulmonary fibrosis, and pulmonary hypertension as well. So some goals of treatment, a couple of the main goals are to prevent occurrence or progression of bronchiectasis, to prevent the decline in lung function, and to improve the pulmonary physiology of the patient. So inhaled steroids are not shown to prevent acute episodes, so they're shown to treat. Oral corticosteroids are the basis of therapy. Recommended treatments are usually 3 months of an oral corticosteroid, such as prednisone, at 0.5 mg per kg per day for about 2 weeks, and then alternating days for 3 months, followed by staging of the disease. There are different clinicians will choose different ways of prednisone. So the favorite treatment is 0.75 milligram per kilogram per day for about 6 weeks, and then bringing it down to 0.5 milligram per kilogram per day for 6 weeks, with a reduction of 5 milligrams every day for every 6 weeks, with a 6 to 12 month period of treatment. And then acute treatment, like I said, can be anywhere from 0.5 to 1 milligram per kilogram per day. Usually, if they have a flare-up, you'll increase their prednisone dose, and then the goal is to taper it back down to where they were before the pre-exacerbation dose. Unfortunately, there's no controlled data to compare these dosage regimens. Most recent studies will show that they do favor the higher dose regimens with duration of treatment determined by serologic and clinical response. In particular, aiming for 35% reduction of the total serum IgE to reduce the risk of relapse. So in terms of monitoring, we follow IgE levels initially, then bi-monthly to monthly, and then you can follow them every 6 months to every year. So a decline in serum total IgE of 35% is considered diagnostic of achieving remission of ABPA. Although not all patients will achieve such a reduction, especially for those patients that have an IgE level that is less than 2,500 international units per milliliter. So you really need to look at how they're doing clinically in terms of their symptoms. Moreover, a doubling of serum total IgE is considered diagnostic of relapse of ABPA. Lung damage can occur even in the absence of symptoms, so it's very important to monitor serum total IgE levels every 1 to 2 months and increase corticosteroid dosing if IgE levels double from the baseline values obtained after stability on the maintenance dose. So a chest x-ray can be repeated after initial treatment, and it may also be beneficial to obtain it every once in a while to follow these patients with ABPA, as recurrent exacerbations can initially be asymptomatic, and an infiltrate on chest x-ray might be the first sign that they're about to have a relapse. So other therapies that can be used. Clinical improvement has been seen with the use of 200 milligrams of itraconazole twice a day. Liver function should be monitored regularly, and the treatment is typically for 3 to 6 months, although this varies depending on the response of the patient and if they're having any side effects. The mechanism of action is thought to be due to a decrease in antigenic stimulus that causes inflammation in the bronchi. Another proposed hypothesis is that it also causes increased levels of serum corticosteroid by interfering with its metabolism through the first pass metabolism in the liver. A major concern is that adrenal suppression has been observed with concomitant use of corticosteroids and itraconazole. So that's something to make sure that you're watching out for in your patients. They've also used voriconazole and posaconazole as they have improved tolerance and bioavailability, but there really are no studies to show that it is superior to itraconazole. In general, the antifungals, they have good utility in ABPA that is seropositive and can also be used in ABPA with central bronchiectasis, but like we said, ABPA that is seropositive or sensitization, the fungal sensitization, so levels less than 1,000 international units per milliliter, it might be more beneficial in those patients. Adverse effects, so 19 to 39% of patients can experience hypertriglyceridemia. We said liver abnormalities as well as hypokalemia. So very important to be checking their CBC as well as their CMP and their LFTs and lipid panels. This can also interfere with steroid metabolism like we talked about. It has also been used as a steroid-sparing agent. So for example, in patients that are unable to take steroids, this could be a good alternative. Xolair has also been used as a second-line option. Case series report effective use of omalizumab in ABPA patients and in corticosteroid-dependent cystic fibrosis patients as a corticosteroid-sparing agent as well. Effective use of omalizumab with corticosteroids in life-threatening respiratory failure, it can be caused by ABPA. It's Xolair. So it's it's anti-IgE, monoclonal antibody. So the use of nebulized amphotericin B appeared to reduce symptoms and exacerbations in separate studies of ABPA among 21 patients with asthma and 3 patients with cystic fibrosis, but really not much data seen with amphotericin. As well, so some people have questions about immunotherapy for ABPA. Immunotherapy with fungal allergens has not been evaluated in any high-quality studies. Evidence to support the initiation of fungal immunotherapy for the treatment of ABPA really is lacking, although patients already receiving immunotherapy for treatment of other allergic disorders may safely continue it. So back to our case presentation. Our patient was diagnosed with ABPA and started treatment with 40 milligrams of prednisone daily until she followed up in the clinic. At her 2-week follow-up, she had a marked improvement in her asthma symptoms, but continued to experience some nocturnal chest tightness and coughing. At the time when she came in, her spirometry showed an FEV1 of 1.23 liters, or 83%. She had a ratio of an FEV1 over FVC of 59%. And then she also had some small airway obstruction that we see. And her IgE level at the time when she had followed up came down to 1,350 international units per milliliter. Her eosinophils, of course, were negligible because she was on prednisone. Her prednisone dose at this point, because she had improved, she did meet the 35% decrease. It was reduced to 40 milligrams every other day. And she also had QVAR, which is beclomethasone, an inhaler that was added to her regimen. This inhaler has very fine particles that are able to target the small airways and improve small airway inflammation. So on her 1-month follow-up, she had dramatic improvement in her symptoms and minimal nocturnal symptoms. So her repeat spirometry showed an FEV1 of 81%, which was 59% at her 2-week follow-up. Her FEV1 was 53%. Her FEV1 over FVC was 80%, and that was 59% at her 2-week follow-up. And her small airway improved, and they're at 51% on her 1-month follow-up. Her IgE level remained relatively stable at this point, so it was 1,410 international units per milliliter. And because she was doing so well clinically, her prednisone was further decreased to 30 milligrams every other day until she followed up with us. So she continues to follow up regularly. Actually, she's coming to the clinic tomorrow, and her prednisone dose will just be adjusted according to her clinical course. In terms of how she's feeling, the patient says that now she's able to go to school. She's never felt great, never felt better, and she's doing really well. So in terms of prognosis, the natural history, progression, remission, and recurrence of ABPA are not well understood. There's still a lot of research being done. If treatment is initiated before there is permanent lung damage, so before bronchiectasis or fibrosis develops, there should be no progression. Relapses can occur many years later, so these patients need very long-term follow-up. And patients without central bronchiectasis at the time of diagnosis tend to maintain their lung function despite occasional exacerbations. So these are my references. And any questions?
Very nice presentation. Open for questions.
How often do y'all do the x-rays all of after?
So there isn't any guideline that says specifically you need to do them. I read that the recommendation is that you can do them every 1 to 2 months, depending on how the patient's doing. If the patient is doing great, you can even consider doing it like once every 6 months, just to make sure, because it can be an indicator of a possible relapse without any symptoms.
I guess I'm a little confused as to why the antifungals are not considered first-line therapy over the steroids. And I understand the complications of things, but we certainly have those with long-term steroid use too. Is it because it's hard to eradicate the fungus within the mucus, these mucus plugs and things, or what? I mean,
Yeah, that's a good question. So they do find that steroids, well, I guess with the antifungals, there are a lot of side effects from them that you have to be careful. But they found that, in fact, patients who are actually on steroids, and if they don't improve, adding antifungals can also be a first-line option. For example, in patients with fungal sensitization, so when their levels aren't as high, antifungals can be considered first-line therapy for those patients, and they've done studies and found that it works better for those patients. And in patients with an IgE level that is extremely elevated, they've just found that corticosteroids are the mainstay for treatment for them.
So the other thing, this is predominantly an allergic disorder, and so that you're going to keep getting exposed to the organism on a regular basis, you have to control the allergic symptoms, I think, primarily.
Well, I think Dr. D'Mello questions was for several years. It started as it is a hypersensitivity reaction. And these patients, whenever they were given for definite diagnosis, a short course of steroid, you can find propaganda. So that's why the prolonged course for months and years. It makes sense, of course, if the person is allergic to dog, remove the dog. So kill the fungus. But there are some authorities are hard-headed, most of them are, unfortunately. And they didn't want to change easily until trials were done and said, we added the antifungal and the improvement was fast. I am of the second group, sorry. Although I appear hard-headed, but I'm not really, I'm soft hard. It's not like that. But they have to change our mind for that. And this case illustrates at least a couple of things. The prevalence of this disease is about 2% in asthmatics. We discovered one patient a year or every 2 years, whether we or pulmonologists, and it's primarily adult problem. But still, even adult pulmonary is not discovered, meaning we are missing it. We're just treating as asthma. Asthma is not one disease. It has many underlying causes and comorbidities. This is just one. Why the patient is not improving in spite of traditional asthma treatment? What is it? Control of rhinitis is important. Sinusitis is common. GE reflux is exacerbated. And environmental factors with it. Maybe cystic fibrosis and being missed. And this call for the general pediatricians, particularly in a teaching institution, don't be reluctant to ask the opinion of the specialist. You are in luxury to have That's all specialists in the same building. And in our service, we welcome that. Don't consider it you are ignorant. Please don't do that. We learn from each other. So if you have the luxury that you deal with the patient, consult the specialist, and specialist will tell you you are doing a great job, that pleases you and helps the patient. Second, we'll hook that patient with the specialty clinic. We deserve in an advanced country and in a medical school that the patient receive the best treatment from the specialist. And this is a teaching institution, in addition to the benefit to the patient. The residents, the students, the fellows, the faculty, all of us were learning. And we discovered these rare diseases that we are missing in that. And I give credit to Dr. Calacondi that he collaborates very well with us. The same thing with adult pulmonary. They send us their patients that are complicated. And by dealing by 2 or 3 specialties, we may ask Dr. Bencherian, Dr. Bocchini, what's the best antifungal for this organism if we identify it? And we do all that to help the patient. And although I'm encouraging you a lot to involve the specialist, who are speaking for ourselves in particular, please be considerate. If we give you the numbers of consultations on Friday afternoon on patients who are being for several days in the hospital, why? Friday is the busiest day in the clinic, all of us. Why in the afternoon in particular the numbers are the highest? And the patient has been. Another thing, how many patients you told us the patient's leaving today? Well, it has been for several days. And you consult us this now. Are we sitting on the shelves just pull one of us go? Why just the patient is leaving today? Well, it's charging. If it is an emergency, no problem at all, we'll run. I would appreciate getting this, but it helps. Once you hook the patient with a specialist in the hospital, we will adjust the plan and we give the appointment and we make face-to-face contact. This case and this subject is important, particularly it is rare in children, which is stimulated. Rashmi and Dr. Calacondi to write a review on that subject and has been already accepted for publication.
I think that's great. So I think, go ahead.
One thing very important message from this case, he started treating her and she did not have bronchitis. If she remains unrated for a few more months or 6 months or 1 year, that she will most probably she's going to develop bronchitis, which is, I have seen patients with APP with bronchitis, which is very, very difficult. It's irreversible. They don't have productive cough and lung symptoms and infections for the rest of their life. So we got this patient before she developed bronchitis. So the message is the high index of suspicion is that in children asthma remains uncontrolled, irrespective of the severity of asthma, especially. So if the asthma remains uncontrolled, your crop should start getting why this is uncontrolled. You start addressing different problems that Dr. Prana mentioned, the trigger, in fact, pulmonary triggers, the comorbidities, at the same time also suspect this kind of CBLUS, like LDPA, pulmonary eosinophilic syndrome, and you find out there may be only 1 or 2 patients there in that cohort, but find out those patients there, and you can say that.
I think it'd be pretty easy for a 12-year-old who's coming back with persistent symptoms to consider that this family is non-compliant, as opposed to having something else as being responsible for her symptoms. So I think it's really important to assess compliance, but at the same time, it's important to kind of consider other things that may be going on, as you guys did, to help make the diagnosis. And you did mention that most patients really present in their 30s and 40s, or third or fourth decade, and here's a child at age 12 with this disorder, so it needs to be something that you consider under these clinical circumstances. So what about the CF patients? With a rate as high as 15% in CF patients, do you routinely screen those patients?
Yeah,
So
every year,
so that's a different.
Weight protocol given by the foundation. Every year we do a screening IgE for the patient.
Yeah.
So that's a protocol.
Yeah.
So there is no set protocol for asthmas, but every uncontrolled asthma, it doesn't have to get an IgE level.
Yeah. Okay. All right. Any other questions or comments? Rashmi, thank you for a very nice presentation.
Thank you.